But primary care is frequent, highly predictable, readily affordable, and to be encouraged. We want people to get primary care. We want them to use it. In fact, we're better off having people use and abuse primary care than any other part of the healthcare system. There's only a certain amount you can do in primary care. You can do a lot, but you can't do expensive, invasive, dangerous things to them. And if you give them a lot of primary care, as you saw with this slide I showed earlier, you're going to prevent them from needing a whole lot of other things. So, insurance, my message is critical to healthcare in this country. We need insurance to cover people for those big, bad, disastrous events that could wipe them out. Everybody needs to be protected from that eventuality. But if you use it as a payment mechanism for frequent, small cost, predictable, expected, desired events, you're adding a layer of administrative costs and complication to the system that doesn't need to be there. So just to think of the analogy of the car accident or the car insurance, imagine what it would be like if we had insurance to cover gasoline, tires, tune-ups, all those kinds of things. If you went to the gas station and had to submit a claim to get gas for your car, you know it would be $5 a gallon, not $2.50. So, right here on this slide is my answer to how to fix the healthcare system. Now you might say, that looks horribly complicated, that's not simple at all. That's the point. This is a typical primary care visit, where a person calls up and they say, well, I've got a fever of 102, I'm coughing, I feel awful, what do I do? Typical insurance-based offices that don't have good access, which is a lot of them because they're taking on too many patients to try to make ends meet, they say, well, we don't have any appointments today, can you come in a couple of days? Well, I don't know, I'm really sick, I'll try to hang on. Maybe they're so sick they have to go to the ER that day. Or maybe they wait for their appointment and they come in. Well, they come in, and don't worry about what all these little boxes say, but the point is, yellow is the patient, blue is the provider, and red is everything to do with the insurance billing process. So every step along this pathway starts a loop of insurance-based claims processing. And if it goes through the first time, great. If it has to go through a couple of times because we didn't code it correctly, or connected two codes that don't belong together, or something like that, or the date was wrong, or you name it, that claim keeps going round and round and round until it gets paid. And if it gets rejected, it gets sent to the patient and say, sorry, you have to pay. Then the patient has to call the insurance company and call the office. And this is a simplified version of what actually goes on. So you can see this is pretty much a disaster. And what happens to costs is that you've got a high level of burden on primary care that it can't sustain because it's already pretty low cost. So the fixed costs of administrative costs of claim processing are a huge percentage of the total amount. So if you look at $1 spent on primary care, basically over 40 cents is spent on just processing the claim. And if it's a for-profit insurer, a little bit gets put into profit. Not as much as people like to make it out to be. Really, the vast majority of this money is going to claims processing, both at the practice level and the insurance company level. So what does this do to our overall system? You've got an insurance-based fee-for-service primary care system with too many patients, not enough time, poor access, poor level of relationship between the doctor and their patient, limited preventive care, little to no care coordination. It's very reactive. And so it can't address that 90% of things that people are coming in with, and so they get pushed to the rest of the system. More lab tests, more studies, more specialist visits, more ER visits, more hospital care, more expensive end-of-life care. And that's what's driving the inflation of health costs in this country. So remember this one again, this really messy, ugly slide. And now this is Keylights. So we've removed all the insurance-related claims processing-related costs from the system and aligned everything so that we are working with our patients directly to get stuff done. So at Keylights, a patient calls, they said, I got a fever and a cough. Great, can you come in? How soon can you come in? We always have appointments available that day. Now we're open till 7 p.m. If they call at 6 o'clock and they can't get in until 7:05, okay, we're out of luck for that night. But we're open from 7 to 7 Monday through Friday, 9 to 2 Saturday, 12 to 4 Sunday. Usually they can get in. And usually they can get in with their own provider. And if their own provider isn't there that particular day, then they can get in with somebody else. We get them in, we see them, we can do an x-ray on site, we can run labs on site, we actually have a dispensary on site to give them antibiotics. If they need IV fluids, if they're vomiting, they need medication for that, we can do it all on site. That person now does not have to go to the ER. They've attacked their illness day one, and they're likely to recover a lot faster. That means less medical expenses. It also means they're going to go back to work sooner. Everything works out better for them. So, how do we work? The three basic parts of this that make it work are, number one, we're a low overhead practice because we don't have to have a big billing office. We have a recurrent source of revenue, which any of you involved in business know is a great thing to have. If you have a consistent amount of income every month, you know what it's going to be, you can plan your business, you can plan your services, you can plan exactly what you're going to do with your patients. You can plan how much access you can offer them. You can actually present them with a plan of services. They can say, I like it, sounds like a good deal to me, I'll buy it. If they don't think it's good for them, they don't buy it. We are responsive to them. And finally, we support this with advanced IT and business processes. We limit our patient panels pretty dramatically. You saw the group health limited their panels from 2,300 to 1,800 patients. We think it should actually even be smaller. Most of our providers have a maximum number of patients of 800 and have 10 to 14 appointments a day. I talked a little bit about our schedule. Excuse me. Our appointments are 30 minutes to an hour, depending on the need, and annual physicals are always an hour. We very much work with our patients to develop a good relationship so that we can help them figure out when they really need to have an appointment with a specialist or not. And when we do send them to the specialist, we rarely send them off to just get all their care from the specialist. It's generally for a true consultation, and then the patient comes back to us and we continue their care. We charge $39 to $79 a month for our basic service, which is outpatient care and remote coordination of referrals and hospital. And it's a little bit more if you want your doctor to go into the hospital and see you. Some of our older, sicker patients elect to have that. We have X-ray on site, as I mentioned, some of these other services. We've also pre-negotiated cash discounts within the rest of the system for labs, radiology, imaging, specialist care, etc., for our folks who don't have insurance. And one of the nice things is this model really makes the high deductible health plans, with or without an HSA, really hum. Because now they've got really great primary care on the front end, which has been the big downer of the high deductible plans, is how do you get people to go and get primary care when now they're having to spend their own money up front. Well, if you put Keylights on the front end, 90% of what they need is taken care of. And then they're going to have some intermediate expenses, and then they've got their high deductible coverage to cover them in case of catastrophe. So I'll let you kind of look at this slide. We do everything that any primary care office does and more. We do lots of procedures on site. Everything we do with our head and our hands is included. So if I do a procedure on somebody, that's included. No co-pays, no deductibles, no visit charges, nothing like that. The few things we charge for them at cost so that our incentives are aligned. I'm making money from my patients on their monthly fee, not on how many lab tests I sell them or how many procedures I sell them or anything like that. And we really emphasize that it's about building relationships and trust between the patient and provider, which are ultimately the only thing that really make primary care work. Finally, this pulls all the costs into the system, into primary care, away from the expensive parts of the system. And I'll just show you this last slide, because I'm out of time. So again, just to wrap it up, we are eliminating insurance from primary care. We think it's the wrong mechanism to use for payment. We are paid directly by our patients. We work for them. We're responsive to them. We eliminate fee-for-service so we can focus on whole person care over time rather than disease-oriented or episode-oriented care. And we provide exceptional access so people will not need to use the rest of the system, that they'll be able to get what they need from primary care. So thank you very much, and I look forward to your questions.